We are the heart failure program coordinators. So a little bit, give you a little information about us here. Our pictures.
We included this since we're not on campus right now, and usually we see all the nurses and interact with you on a day-to-day basis. And then with COVID, we've kind of switched and are remote. And so we're doing all of our duties remotely rather than in person. So we just wanted to show you what we look like so when we do come back on campus, you can recognize us, and we're also available in the Vault if you ever need to get a hold of us.
Yep. So what do? We lead a multidisciplinary team. We have oversight of the heart failure patient care. That includes educating the patients at the bedside, or right now we're doing, like Sarah said, we're doing that remotely over the telephone. And educate fellows and then do fellowship, stuff like this. We analyze heart failure patient outcomes. We facilitate performance improvement projects. We do provide heart failure patient education over the phone. And then we also do discharge follow-up phone calls with the patients that we talk to in the hospital. So we're able to connect with them in a couple of different ways, which is helpful to help them stay on their plan. And we also maintain a joint commission, or maintain our joint commission certification. We oversee the standardization of all heart failure patient care across the Nebraska Medicine campus. Right now, we're not seeing patients in Bellevue, but maybe in the future, that's something that we'll do. Right now, we're not doing that though.
And on this piece too, we just want to make sure, so we don't just see cardiology team patients, we see internal medicine, family medicine, cardiology, private cardiology. And so those are all patients who roll up into our Joint Commission certification, who CMS has, they've given us guidelines of what we need to follow.
Okay, so why do we do all of this? Heart failure is a big issue in the United States and abroad. It's expensive for patients, it's expensive for hospitals, and because of not just the cost, but the cost for patients. 50% of heart failure patients die within the first 5 years of diagnosis. So that's why we have jobs. That's why we do what we do. So we can help the patients feel better at home, help them understand what they can do about how they can affect their own self-management and how they can stay out of the hospital. What do we need from you guys? So as you know, on your admission screens, the cardiac screen is part of that. So when you complete that, it helps identify patients and that prompts us to see patients. Initiating the heart failure care plan and then adding the education points in. We know right now you're not doing that because of pandemic, but once that comes back, obviously that's something that you will be able to address. Reviewing self-management when you're at the bedside and doing assessments and at discharge. We know that you're educating patients, so take credit for that. Reinforcing and documenting when you provide education, and then making sure the patient is flagged for heart failure core measures. And then there's a little link. If you get this sent out, there's a little link to show you how to do that. This is what the heart failure screen looks like. Obviously, when you're doing it, any score of 5 or above will send a prompt and notify Sarah and I that there is a positive screen. So we review their record and see those patients. This is, we also get notified by a physician consult. So this is what that would look like when we put in a note, but that also sends a notification to Sarah and I to review that patient's chart and to see that patient. This is just a little documentation of your care plan. Pick the right care plan for your patient, acute versus chronic. and then adding the education points in. This is what the education titles for the heart failure patients when you're educating them. So there's required, the heart failure required documents, and then if they have any advanced therapies, you can select those as well. Making sure that you add the co-learner. If they have a family member in the room or a caregiver, it's always important to address who the caregiver is. So taking credit for the work that you're doing is just kind of what we're trying to point out here. Who needs heart failure education? Well, obviously the patients, but their caregivers. A lot of studies have shown that having social support of their family and friends or caregivers will help patients adhere to their medication plans, their lifestyle changes, like with their diet and low sodium diet, because that's probably one of the harder things for them to change. And then it also has evidence of lower readmission rates. It's always nice to have a backup person listening to the education when you're providing it. It just sometimes when you miss things, when you're sick or stressed in the hospital, your caregiver will pick those things up. So how do you know what to educate? There's little tips on the side, a description of different things that you should educate on for that each topic. And then documenting every day from the required elements of the heart failure plan. Include the caregivers if you can. Just, we know that you're talking about their diet when they're eating. We know you're talking about all those things. So just make sure that you take credit for the education that you're providing. So our multidisciplinary team is us, nutrition, pharmacy, and then we also do the follow-up phone calls. And then we also included a little picture of our Living with Heart Failure book. So the unit should have those in stock on each unit. And so if you're able to give them to them, it really helps have something for them to look at. We're working on possibly getting that in another format so they have it as a reference, but it's nice to have that especially if it's their first time being diagnosed. So I appreciate you guys, your help with that. Thank you.
All right, so within that book, we cover each aspect of of managing heart failure at home. And so it's just something that we want to point out, though, is lifestyle changes, because many of these patients come into the hospital and they have never taken medications, or they've never had to go to the doctor, or maybe they just kind of never wanted to go to the doctor. And so it's a lifestyle change. So we're telling them that they need to be careful with their salt intake, that they need to take medications every day. And these are things that they need to do, every day. We can't cure their heart failure, but we can manage their heart failure. And so it's just working with the patient of, them understanding what they need to be doing at home. And so within this heart failure book, there's just kind of goals that the patient can set. Because, telling a patient they need to do all these things at home, and then they get home and they're like, how am I going to do this? So the book is kind of set up to help them set goals once they get home, or they can start them in the hospital, and then when they go home, kind of helps guide them. We know that we have patients who don't always adhere to recommendations, and so there is a care plan that has been created. It's called Ineffective Self-Health Management, and this was just something that was identified when Joint Commission was here at one point, that we were not doing a good job of reviewing if a patient wasn't going to adhere to heart failure self-management. Are we telling them the risk? So are we telling them the risk of if they continue to use drugs? Are we telling them the risk of if they don't take their medications? And so it's making sure that we are providing this information to the patient and then just documenting. And so there's a care plan or education point and a care plan to in place. And then these are just resources that everyone has available here on campus. And so like Vicki said, we're a multidisciplinary team. And so we want every heart failure patient who's admitted into the hospital for acute heart failure to have this book. If the patient's been here before, they do not need a second book. And the book really outlines how to manage their heart failure. And then for those patients who are here for advanced heart failure, so maybe they are getting a defibrillator, or maybe they're talking about an LVAD or heart transplant, or, sometimes patients come here and they don't qualify for a heart transplant or LVAD, and it's talking about more of supportive care, and we involve our palliative care team. But I think that I know Carrie is going to, from the palliative care team, is going to talk after this, but I think it's something that, we can't, give every patient an LVAD or every patient a heart transplant. And so it's making sure we have these conversations with the patients early, making sure that they understand that these are their choices. And sometimes we can't offer every choice to the patients, but that's why they come here for advanced heart failure therapies. There's an Emmy video link that's included in their ABS, heart failure educators, the dietitians, a pharmacist, and then cardiac rehab. CMS has now approved cardiac rehab after the patient's discharged for a patient who has an EF less than 35%. And so now it's just involving the cardiac rehab team in these heart failure patients. So while the patient's in the hospital, making sure the patient's getting weighed every day, those weights are getting trended. Talking about low sodium diet. If a patient's having, a big bag of chips and, they have pop brought in, just making sure that, we're talking to them about reading the food label, seeing how much sodium that they're taking in, and figuring out how they can, change this part of their lifestyle. Talking about medications, making sure they understand that this is what's their Lasix? It's a water pill. It's important that you take it on an empty stomach. It's one of the reasons why we want you to weigh yourself every day. So the patient understands too when they need to call the doctor. And then just fluid restriction, not every patient's on a fluid restriction, but just working with the patient when they are on a fluid restriction. So it's not noon and the patient's already drank their water for their fluids for the day and then they're upset. So just making sure involving the patient in these things. And then just again, we just talk about taking credit for the education you're doing. We're not expecting like a 20-minute sit down and talk to the patient. You're educating the patient every time you go into the room. Even just when you take their weight, you can tell them why you're doing it, and that's all education. So it's just same things that you're already doing. So at discharge, making sure the patient has a book. Within the heart failure instructions on the ABS, there's also about a page of heart failure instructions, and the daily weight. So the weight that the patient weighed that morning will auto-populate there. And so it's just kind of pointing out, making sure the patient knows how much they weighed on day of discharge. And then just educating them about making sure they know when to call the doctor with any weight changes or signs and symptoms of extra fluid. Follow-up appointment is super important in these patients as well. That's something that case managers are working on, making sure the patient has a follow-up within 7 to 10 days after discharge. It can be with a primary care doctor or a cardiologist. And then just making sure we ask open-ended questions, because when you ask yes or no questions, you're going to get the response back. Usually it's, what you want to hear. And so just making sure the patient understands, what they need to be doing when they go home. So then that's when we talk about teach back, because we know that teach back patients, when you do teach back with the patients, they have better outcomes for managing their heart failure at home. So asking them, are you planning to take your pills every day? You're going to get a yes, because they want to get out the door. And so asking them, what's your plan of taking your pills every day? If they tell you that they have a pill box and they're going to go home and set up their weekly pill box, and you know that they know how to, what their plan is for their pills. And so just making sure you're using teach back questions and when you're discharging that patient. And these are just examples. If we were in person, we would be getting in small groups and doing some teach back. But here's just some of the examples that we're kind of looking for. So asking them, usually, you have them review the ABS, and then, have them point out what, where and when their appointment is. Having them be able to list out the signs and symptoms and when to call the doctor. Many times when Vicki and I are doing our education, when we do teach back, one of the things we get is when we ask, hey, when are you going to call the doctor with signs and symptoms of extra fluid? And I feel like every time I ask it, we get chest pain. And so making sure that they truly understand those signs and symptoms of extra fluid in the body. And yes, they can be having chest pain, but making sure that they understand it's the weight gain, it's the swelling in their ankles or legs, feeling full or bloated. Those are, those symptoms that we're looking for. And then again, just talking about the plan for taking their medications. And then this is here, the one about when do you weigh yourself? So making sure that they do it in the morning on an empty bladder before they eat breakfast, and then that they record it is also a good part of the routine. So I know Vicki just kind of talked to you guys about our heart failure disease management program, that just is a little bit more in depth of it. So we've been certified through the Joint Commission since 2007. And we are due for an on-site visit in 2021, and we'll just kind of wait and see what that exactly looks like. I know they've been doing a lot through Zoom, so when that day and time comes, we'll be in contact with the appropriate units. We oversee the heart failure care, and we do have representation from HVU and CPCU nurses. And we just want to make sure that we're providing quality care and reducing any variation. So again, standardizing heart failure patient care. Listing out our quality measures there on the left, and then for our Joint Commission certification, we get a self-select for performance measures of things that we have identified within our patient population of what we want to improve. So obviously we want to reduce our readmission rate. Our readmission rate is about 21%, which is right at national average. If we go above, so if we are above national average, then that's when we start getting penalized, and we don't get as much money back for our heart failure admissions. And so that's why it's very important that patients are understanding how to manage their heart failure at home. And, there's sometimes that you can tell them over and over, and sometimes they just do come back to the hospital, or even if the patient falls and they break their hip and they come back into the hospital within 30 days, that is considered a all-cause heart failure readmission. So it's just some, you can't prevent, but then there's those patients that, maybe we can be doing a better job. Making sure that the patients have a cardiac rehab referral. That's something that we're working on. Also, just improving heart failure provider follow-up, because right now only about 30% of our patients see a heart failure provider after discharge. And then we do a self-care confidence survey with a sample of our patients. Some initiatives that we're working on is a heart failure optimized clinic. This is something that we started in 2018. It's a APP driven clinic, and it's about 12 weeks long. The patient comes in and they see a heart failure APP, they see a nurse, and then they rotate between the pharmacist and the dietitian, and they're seen every about 2 to 3 weeks. And so our goal is to optimize guideline directed medical therapy. And so there are medication titration during each one of these appointments, and we've had very successful results. Patients have had improved ejection fraction. So we do a pre and post echo. We do a pre and post 6-minute walk. And then we also do pre and post quality of life screening. And so we've seen, like I said, significant improvement. Patients are walking further. Their ejection fraction has improved to the point that they're not needing an ICD. And so when we first started, our focus was patients who have had more than 2 heart failure admissions in 12 months, or a new heart failure diagnosis. Those are those patients we want to be seen in the optimized clinic. And then we kind of talked about them. Our goals are to improve quality of life, reduce mortality, morbidity, obviously prevent readmissions, just collaborating with other disciplines. So maybe if a patient has a positive stop bang score, the patient needs to have a sleep study. So it's just, or maybe the patient is diabetic and they need to be seen by the diabetes team. And so it's truly a comprehensive approach. And then we just want the patients to understand how to manage their heart failure at home, because quality of life is, living at home, not back and forth to the hospital. So it's having the patients understand how to manage their heart failure at home. So part of these clinics is education as well. And so this is what that appointment will look at like on an AVS. You're going to see 3 different appointments. So they're going to see the nurse first, and then either the pharmacist or the heart failure APP. And so we're just showing you an example. If you ever see this, this is what the appointments will look like. So just some takeaways from today. Make sure that you weigh your patient every day, trend those weights, provide the patient with a heart failure book if they don't have one, document your education, and then just making sure you include your caregivers. And do you guys have any questions? Like I said, we are in the vault if you guys ever need us, and we are available.
Do you guys have any questions for them? I'll take silence as no. Thank you, ladies, so much for your information.
All right.
Thank you.